Thank you, Dr. Brasant, and I'm very grateful to all of you. It's a great pleasure to be this great institution after a gap of 4 years. Same podium where I addressed last when I had a farewell with this institution. And I must tell you, having worked in the private sector now for the last 4 years, I miss the academics of IGP-JAMS. Very vital activity, and that keeps us actually live with the academics. But every day I have to look at the PubMed, search, and apply them on the patients who come across to me. I shall be talking to you on neonatal cholestasis. See, basically everybody knows, I think most of you are pediatric gastroenterologists who are allied to this area. Jaundice and dark-colored urine, alcoholic stools with or without. And it's a heterogeneous group. All of us know that we have got different treatment, variable outcome, and we have two main entities. One is the obstructive, that is the biliary atresia, cortical cyst, and intrahepatic causes, but they all look alike from outside. Hardly there's any difference. And that is a clinical overlap in this entity, and that's why pediatricians generally are confused or they're in difficulty to give the solution. Now, neonatal cholestasis, confusion to consolidation. In 1990s, before that, there was only fire, and chest beating on this condition, that we are not able to get the patients on time, and there was a delayed presentation, and there was a fire. All through, everywhere I used to go and find that these patients are not getting referred on time. One article was there in 1992, that's all. One review article from media on NC. And in 94, I went to King's College. I had a stimulus from Dr. Lex Mowat, and he told me that your patients should be actually looked at in NCS because he would see the number of patients coming from to UK, from India, particularly from Bombay, who are not actually treated for biliary atresia. So he gave me a stimulus, and in 1996, original baseline data was created from IGP-JAMS Galactosemia, and also I wrote a small in Indian Journal of Gastroenterology, Galactosemia as a cause in India. That time we had no confirmatory test for Galactosemia, but it was on clinical basis and some corroboratory evidence on laboratory that suggested a response to diet. 1999, we stated and published Indian scene, distressing, depressing, and dismal. And we gave a way forward for this condition. What was that? National data collection. IGP-JAMS collected the data from 8 medical centers and some surgical centers, 6 surgical centers, and we made a consensus guideline on this issue, and thereafter showed some impact at the peripheral level, whereby the referral and other things started improving to some extent, but not fully. There's also a pathologist, Dr. Krishnani is here. He knows I invited Dr. Bernard Portman from King's College Hospital, London for 3 days for histology here, and also invited national histopathologist to deliberate on this hepatic histology in pediatrics, which was a little bit in the infancy in India. So that was the push which was given, and particularly for biliary atresia. And these are the articles which we published. Identified new disorders at that time which were new to India, which were not known, like Alagille syndrome, many other things. We just showed the case snippets. Now, what is that data? 1008 data. So far, there's no data available. I think all academic institutions should now look critically at NC and produce an Indian data, which can be very large data. And this, we showed 53% of the patients are hepatocellular. There is a 38% are obstructive, and there are some 33% at the time had paucity of bile ducts. Total, lot of pediatricians going tarish, wasting time, wasting money. And we showed that TORCH actually does not have much of role in NC. We are wasting time and money on these things. We should go and actually emphasize on other etiologies. This is the revisited data of IGP-GMS. And where you can see that we had mostly intrahepatic, we had also the biliary atresia. And the spectrum was different slightly, and it is changing now. Now it has changed. Maybe that here and there are changes in the numbers. The priority may go to one entity or the priority may go to another entity. Now you see that the consensus report on neonatal cholestasis syndrome, and this was August 2000 published from IGP-GMS itself. And this is the poster, Dr. Naresh knows, Dr. Georgina Milivargani, she inaugurated this poster at Hyderabad. In Rainbow Hospital, we had that National Conference of Pediatric Gastroentrology, and we actually inaugurated this poster. For biliary atresia, I also want to live. This was the plight, which are really touching to see that doctors are keeping the children of biliary atresia with them and not referring them on time. And thereafter, 2014, under the consensus statement. But the lag in this statement is that there's no additional data from media. It is just here and there they've added, and almost a replication of the same thing which was shown in year 2000. What should be the clarity? See, we are clinicians. So clinicians, what they should do, any child coming with dark urine and jaundice, you are sure about it, it's a conjugated jaundice. Yeah, do serum bilirubin, it will find, and give vitamin K first of all. See, we can see a lot of children with NCO have got the intracranial bleeds, they can bleed and they can have mortality. And therefore, vitamin K should be the first thing to be given to them, irrespective of the etiology. That is a very good step. Using the urine and stool colors, this was not given importance. Now here you can see the upper panel, that is the urine stain. You can see diaper staining, then the stool colors. Stool colors should be seen by the doctors themselves and don't depend on the parents. But nowadays, with the high-tech community, particularly at Bangalore, they will show you on the mobiles, the photographs, the videos, and that you have to accept that the technology is changing, and you may have to accept these stool colors, what they are showing to you. LFT. Non-benefit. We have a lot of banking, giant cell, intrahepatic, biliary atresia, this is that different. No, there is no difference. Gamma GT, very important. Gamma GT usually high in biliary atresia, but normal gamma GT does not exclude biliary atresia. High gamma GT, PFIC3, Alagille, sclerosing cholangitis, and low to normal may be in other PFIC types. Low gamma GT bile acid synthesis effects, very importantly, they are low gamma GT. Now, how do you, general clinical condition, you have to see the patient. Second step is this. Look at the child is whether sick or not sick. This is not given anywhere, but I created in this algorithm because it will give you an idea how we should go, what direction we should give. Not sick. Normally you see in biliary atresia, pale stools. You can also see in the intrahepatic condition. But what is a sick child? Any child for a pediatrician means fever or refusal to feed. But also look at vesicles, and particularly vesicles on the scalp. In herpes infection, you may have a small vesicle on the scalp, and that may give you the clue that this is a herpes infection. Rash, anemia, sepsis, small body, low birth weight, SIP deaths, maternal adverse factors. This makes the child susceptible. He's a sick child. You have to look intently as to what could be the etiology. Next is the other factors being a sick or high risk non-biliary atresia patient. It is not today, the world does not say only biliary atresia. That was our priority in 90s, then 2000 early. Now we have to prioritize the medical conditions also, which are there. Seizures, hypoglycemia, uncorrected coagulopathy, early ascites, recurrent early SIP deaths, that means there is something intrahepatic. Maternal history of stillbirths, abortions, pruritus, and other lethargy and poor feeding. These are the definition of the sick child. Now you have to segregate ALF and other causes, and immediate attention has to be given to that condition. Now there's a array of number of conditions. Recently, ILBS had that genetic cholestasis. That is the intrahepatic or bile acid transporter defects, all come under genetic cholestasis. Now I will show you the cases, what has been actually asked in this particular session. Jaundice, day 3rd of life, persistently pale stools from birth, and okay, everything, liver is palpable, spleen is palpable, and then we see here the first possibility, not a sick baby, persistently pale stools, liver, spleen palpable. Now, what is my first possibility? I'll think of biliary atresia, unless proved otherwise. Now, here you see gamma GT is very high, bilirubin is high, and don't look at other things. The SGLT will be always there, high. And then what do? Second step is ultrasound. But in ultrasound, even at Sakra Hospital, they were not knowing how to do a good ultrasound in the baby with biliary atresia. I tell them, look for the following. Number 1, gallbladder, contractility, pre-feeding, pre-feeding and post-feeding. Triangular cord sign, I will write to them and look at the cyst at porta and look at the intrahepatic biliary. Otherwise, they will keep on saying the adult ultrasonography, what you would see. Therefore, you have to tune your radiologist to this requirement, what do you need in this particular patient. Good size gallbladder with more than 60% contractility rules out almost presence of dilated CP to IBR, absence of triangular cord sign, cyst at porta. These, if they are present, this excludes biliary atresia. Possibility is not there. UAG, in this given patient, what I discussed, rudimentary gallbladder, triangular cord sign, no IBR, no cyst. So this is ultrasound findings are also showing consistency with the biliary atresia. Liver biopsy, as you know, typical features of biliary atresia, and these are different kinds of high magnification or low magnification changes which are seen in this, but ductal plate malformation may be seen in 12 to 20% of these cases, and the prognosis of such cases is bad. Their outcome is not generally good. So this was the diagnosis based on these findings and management. We did a podiatrostomy in this child, successful, and follow-up at 6 months, thriving, weight gain, present bilirubin normal. So that is see, we have not used many things, just simple 3 steps: ultrasonography, state of the liver, LFT, biopsy, and that is the diagnosis, and perioperative cholangiography. And here, if you see, gallbladder is filled, the biliary system is seen proximally and distally also, intestine is seen, everything is patent. This excludes biliary atresia. CT scan, usual. Every pediatrician wants HIDA scan, HIDA scan, HIDA scan. Sir, HIDA done. What is the finding? Non-excretion, therefore subject to surgery. No. Excretion of radioactivity into the intestine rules out biliary atresia. That is the purpose of radionuclide scan. Otherwise, no. Excretion does not, because you know if these stools are pale, They naturally that probably bile is not flowing. So there's no use of doing. Yes, in certain subgroups, I do. They are preterm babies, they are low birth weight. You know, today's world, in vitro fertility, I see a lot in Bangalore. I was not seeing an IGPGI, that kind of group of the patients who are very preterm, low birth weight, who are in vitro fertility, very precious for them. Every child is precious, but precious for them. And there might be a confusion, pale stools, whether it is TPN induced, whether this is this, that. So you may do in a subset of patients radionuclide scan, and this may help you. Special situation. Always remember, preterm baby with pale stool. This is the usual story now. More and more referrals will come from neonatology to pediatric gastroenterologists for this purpose. It should neither be made in haste nor excessively delayed. There may be pale stool in preterm babies because of many reasons which I have enumerated here, and the concomitant issues have to be tackled and observed for the change in the stools. TPN induced, immaturity, so many things are there. So it is the follow-up which is very critical in these patients that is going to guide you. And this is the Taiwan study which has shown that in preterm babies, biliary atresia is as common, if not very much there, but it's as common as you find in term babies. Therefore, you are not ignore. And don't jump also. This is biliary atresia. There's no reason. And case 2, very interesting. Jaundice with pigmented stool from day 10. So, stormy course. Sick child. Very sick child. See all these features, scleroderma, skin bleeds, hypoglycemia, all those things are there. And you find here the albumin protein is less, and then INR is not correctable. That means most likely is in what's called correctable coagulopathy. Is not correctable coagulopathy and the intrahepatic cause. And ultrasound normal, and GRS positive. And GRS positive doesn't mean always galactosemia. So it may be present in many other clinical, but it gives you screening, a test sort of thing. Should we suspect in this particular entity or not? So it gives a little bit of help in diagnosis, because galactose 1-phosphate will take time to get reports. It is not easy, immediately you will get report. It may take 5 days, 7 days, 9 days at times. In our IGPJ, where we have established this galactose, you may get in 2-3 days time. That's okay, that's fine, acceptable. And this child had Klebsiella positivity and galactose was low and treated as galactosemia. Very good results. Next, diet, follow-up very good, excellent, very, very gratifying. And this 3-month-old baby who was diagnosed as a case of galactosemia by us, based on screening, based on the clinical situation, based on the response to diet. And you see here, all those features, hypoglycemia, everything was there. And this patient, LFT also showed the changes. And management, we had put on urine culture, blood culture were positive. And he was diagnosed as a galactosemia, high index suspicion. Although we are not confirmed galactosemia by enzyme test, lactose-free diet was put, child showed excellent improvement. But private lab, he went to private lab to get this caliput. And what did they do? They did it. And they said galiput is normal, so you can start on lactose. And he was started on lactose. What happened? Rapid downhill course. He died in our ward emergency and scarred. So that is how the wrong decisions are taken by the labs. Everybody in India is a doctor. Grandfather, grandmother, uncle, auntie, friend, everybody. And Google is the important friend of actually all the people now. I will talk about that tomorrow. So this is our data which we published in Pediatric 2016 on Galactosemia. This is the only paper so far. And this was the experience. And very nice paper, actually. This attracted actually to editorial in Pediatrics. You can see editorials. They are from genetics as well as from the pediatric hepatology. And they were well appreciated at that time. Whatever comes in your way, whatever new you find, publish it. Unless you publish, nobody knows. And it is an education for the rest of the country. And this was the data follow-up, and it showed somewhat delay in the language, fine motor delays in some, hyperactivity despite restricted galactose-free diet. And that is always understood that maybe endogenous production of galactose in these patients despite restrictions. And case 4, pale stools, weight gain poor, pruritus, immediately relief. This is 1 year old, but onset in the neonatal period. I should not have brought it because it's the onset in the neonatal period and going on to 1 year, and that is the pruritus. And we know this could be one of these conditions: PILBD, Alagille, alpha-1, PFIC, neonatal sclerosing cholangitis, it can give pruritus. And this is the classical case of Alagille syndrome. Faces, liver, spleen, and cardio, the systolic movement in the cardiac system. There's another child, facial features, you can see broad nose. This is Alagille syndrome. And always in Alagille syndrome, look at the parents also. They may have some features of Alagille syndrome. And ultrasound, nothing showing gamma GT is high, bilirubin is high, and all the features, tarsus spine positive, lipid profile, echo showing stenosis, palmonic, and liver biopsy showing positive bile ducts. And final diagnosis is that it is Alagille syndrome. Now, if you can give UDCA, rifampicin, allopurinol normal, but pruritus is difficult to control. This is a condition where there's a quality of the patient is affected very badly. It is not cirrhosis that much because it's a slow process. And pruritus is uncontrolled, then biliary diversion. When Naresh has a good experience of biliary diversion. And this is natural history. It is quality of life in Alagille that is affected. And indications of transplant. There's this time competition in private sector mostly for transplants or Alagille syndrome transplant. No. You should have your own conscience, go by your principles, conviction. A lot of children in Bangalore come to me because of my experience. They see this man has 35 years experience, 40 years experience, and they come to me for opinion. I say not at all that transplant is required. So refractive pruritus, not responding even to diversion, disfiguring xanthoma, and most importantly, now bone fractures are become an important indication for transplanting Alagille syndrome. Liver failure occurs in very few. 90 days child, pigmented stool, not sick. And here you see UAG normal, bilirubin is high, and all other things, investigation done for cholestasis which are relevant are negative. Liver biopsy, giant cell transformation, no other features are seen. And idiopathic, we label him as idiopathic neonatal hepatitis, but I don't stop there. Any child who has idiopathic giant cell hepatitis, I will not stop at 2 months and give him the final label. No. What I will do, I will follow this patient. I'll look at the follow-up till maybe 1 year, 1.5 years. You find in these patients, splenomegaly regresses, bilirubin, hepatomegaly, AST, ALT should normalize, and everything should be all right. Despite that, in present day time, we never know, because there are remissions and relapses in a lot of cases of cholestasis. They might be some of the metabolic, some of the unknown entities. Therefore, a follow-up is very important in these patients. Now, this is a Sakra, Bangalore hospital patient, 58 days. See, last year, fever for last one month, off and on, not high. And birth weight is very good, 3 kg, full term. Bilirubin very high, 17, direct. OTPT high, gamma GT 63, which is normal. Albumin low, INR high. Now, what is this patient? Feeding well, weight gain is good, liver is palpable, spleen is palpable, supreme dullness is there, and all investigations done in this patient by us, by negative. Alagille, bile acid, mitochondrial cytopathy we looked at, tyrosinemia, galactosemia, all things, whatever you see, is not there. And sepsis work was positive, although the cultures were not showing anything. Child was given antibiotics, responded in 10 days, and then started on the supportive therapy. Child remained stable throughout the hospital stay and was discharged. So this on follow-up also remained well, normal, and clinical exome sequencing done from medgenome that time, not suggestive of any pathogenic mutation. So we can say, what is the diagnosis here? Decompensated neonatal cholestasis, sepsis induced, most likely. But word of caution in this patient, I've kept this child on follow-up. I have not yet given a clear on that, yes, the child is perfectly normal. You have to keep a follow-up on this patient. Why it is happening so much? Although every investigation is negative, exome sequence is also not showing anything, might be after some time. So we have to have a word of caution where we have an idiopathic variety or sepsis-induced variety. Sepsis is basically exclusion. It is not inclusion. And PFIC, you all know, 1, 2, 3. Now, nowadays, bile acid transport defects are addressed, and we know this PFIC2 is a rapid dominant course. They will go into early cirrhosis, and these are some of the features which they have. I need not to dilate on them. And we know that gene proteins are defective. Everybody knows about them in 1, 2, and 3. And after some time, what happens to PFI? There's a slide from AGPGI. And most of my slides are from AGPGI because I worked here for 28 years. And cholestasis, you see what is happening to these PFIC patients. Debilitation, irritability, poor attention span, all things, decreased school performance. So the quality of the patients is very bad, the pruritus. So in such situations, we may do biliary diversion if it is appropriate, or go for transplantation. Now, newer entities, which recently we had ILVS, these PFIC 4, 5, and 6, and the genetic mutations are there. They are still evolving. And the final word has not been said on these entities. It needs this, what can we say, more number of cases, more number of years of follow-up are required to say the final word. Natural history of PFIC 2 bad as compared to 1. Case 7, 16 days old, you see here, liver and GI. That we say GI and liver are together almost. They are cousins. We can't ignore, only emphasize on liver and leave the first entry, gateway, that the GI. Very important. So GI is equally important. And Greece, now the hepatology people also, including Dr. Daman, our great friend from King's, he agrees, yes, GI is important now. Previously, they were not agreeing. So we always say GI and liver, they are both cousins. And they should be actually seen together. See here, renal stones, the maldigestion or malabsorption. Ecchymotic nodules, now it is related to something coagulopathy. Jaundice with high-colored urine, liver, and pigmented stool. And here you see the eldership had the same kind of problem, cholestasis, statoria, ecchymosis, night blindness, fractures after trivial trauma. And examination we found in the index case, there are economic spots, there is icterus, and there is a organ mechanism. And this patient had low gamma GT. Low gamma GT, cholestasis, greasy stool makes you to think that we are dealing with what's called the biliary synthesis defect. And here the exome sequence has been done. We showed that this is a homozygous variety of biliary synthesis defect. So low gamma GT, malabsorption, maldigestion, I would say, rather than absorption. It is trying to find what is the, you don't have the enzymes to actually convert it or bile acids to help in conversion of the fat, and that there is steatorrhea. So that is the bile acid synthesis defect case, and this should be recognized more and more. So bile acid levels should be down, which were low in this patient, 0.3, you can see here in the slide. And natural history, they do very well. If you give them treatment, cholic acid or deoxycholic acid, they do very well with the treatment and they become almost normal, but they are dependent on the treatment. Tyrosinemia, all of you know, there's a defect in the pathway, and type 1, we know type 1 is there. Hypoglycemia, diagnosis is by screening. Alpha-1 fetoproteins, that should be level should be high. What level we should take? High. So mean, what I found in different articles is 160,333. You can now interpret yourself, and median is 62,000. So anything above 50, 60,000 should be taken as positive, because the young babies, infants, neonates may have particularly high alpha fetoprotein. So there, what is the cutoff which we should take into consideration? And confirmation is by urinary suction-like stone. Now, I asked in Bangalore, where can I get this urinary suction-like stone? All the labs, big labs, commercially very viable. They said, we sent to Bombay, urinary suction-like stone. I said, how long it takes? 48 hours, you said me courier. It's a volatile substance. You will get negative results, even if the patient has got tyrosine. Then one lab started doing, on my best, they have started doing urinary suction stone. It's the mass spectroscopy which can be diagnosed, and it should be fast transported to the lab. That's why I tell my patients, you go and yourself give the sample there in the lab, within 1 hour, it is transported. So that is important thing. And NTPC, diet, both coupled. It is not only drug, but also the drug therapy. This diet therapy is important. Liver transformation only in emergency. And this is the one which is now available. This is now available by the Loris Labs. They have started this. You know that creatine also has been started by this lab, and that's available in this country now, although expensive. But nitrosinine capsules, I asked them last time at Delhi ILBS meeting, where is this? They said next month we are going to launch. So it might be, it is already licensed here in India, maybe launched in next 1 month. And dietary therapy, you know what are the dietary items? We are more as pediatric GI as dietitians, rather than dietitian giving advice on our children. And this is therapeutic formulation. They say it is SSAI approved, lot of formulation. They are not available in the market. What is happening? Naresh, you know anything about this formulation, tyrosine formulation available? Indeed. Not available. So there is one lab in Bangalore that is pristine. You can ask them, and they make good formulation. There's an Indian company which can make a lot of formulation, but only problem with them, taste. Children don't accept easily. And parenteral nutrition is very important. You should know about it, that parenteral nutrition and sepsis, particularly in young babies who are born 28 weeks, 30 weeks, 32 weeks, high end, high risk, they are subjected to parenteral nutrition. They may have sepsis, most of them have, and they are prone to cholestasis. And they develop neonatal cholestasis. So you have to take into consideration the probability of TPN induced and in the younger babies in neonatology practice, cholestasis. What has changed? In the last 10 years, a lot of things have changed. In NC screening, diagnosis, outcome, therapy, all has changed. And novel ideas in screening have come, not yet in practice. And new entities, diversification, clarity in natural history has come. And genomics has gone in a big way. This is going to determine the future of human diseases, genomics now. And basic sciences also advanced. But these people who do basic sciences are paid less as compared to all those who apply it. And they are actually founders. They are the people who are doing actual science. So that's the dichotomy. Genetic intrahepatic cholestasis, a lot of new things have come. And what has changed in the last 10 years again, shrinking idiopathic variety. As I said, that you must have a follow-up on idiopathic variety. Just don't pass it like that. So it is shrinking because the different entities are being diagnosed. And better screening tools may come. New drugs are available now, especially biologic transporter medicine are available, but they're expensive, not still available in India. And synthesis defects, bile acid have been diagnosed. This is the card which we have created from AGPGI. It is still to be pushed by the Pediatric Gastroentrology is not pushing the thing. And they should push, all states should push your own card. What is the problem? You must, I keep on my computer and show to the patient, what is the color of your stool? Have you seen? See, look at this thing. And they show me exactly the stool color in this card. So it is going to be very helpful if it is distributed at the family level to the mothers, and they will recognize this entity very early. So society is changing. Not to forget vitamins and nutrition supplements in NC. This is my old slide.